So I'm Dr. Robert Watkins the fourth, and I'm really honored and excited to have my guest on, Reggie Scott. Thanks for being here, Reggie.
Oh man, thanks for having me. Really appreciate you.
Yeah, you've been. I'm glad we could finally do this. You have your 1 week of an off season, and I appreciate you taking one of the nights to spend it with me. So thank you.
This has been about a year and a half in the works. I know it has, so I'm glad we finally got to get together and do this.
Yeah, yeah. Much less COVID interrupting us. So tell us a bit about where you're from and what you got into being an athletic trainer. What inspired you to take down this path?
Oh man, number one is it's caregiving, right? Just have the heart of caregiving. Love to take care of people. Always had a passion for that, so that's pretty simple there. That lines up a lot with medicine and what we do. Played sports growing up, baseball player, love sports, love to be around sports, and actually had a pretty good knee injury where I got to first really have my encounter with athletic trainers and physical therapists, and I always thought that what they'd done for me and how they made me feel. I was like, man, I would love to pay it forward one day and do that. And that got my first my wheels spin a little bit about it. And then once I got to college, doc, and really started learning about the professional athletic training and the anatomy and rehabilitation and orthopedic assessment skills and all that stuff, I just caught fire, just got addicted to it, and just said, man, this is cool stuff, and took off. And here you are now, and now I'm working with the Rams. So it's there you have it. So
Yeah, it's awesome. Well, it really comes through, as far as your desire to take care of people. The way you connect with the players and with everybody is really awesome because a big part about your job is trust. And, you're in the middle ground of management and team ownership and working for the team at the same time. The players, you're the main man. You're the guy that they trust and interact with for every injury they have. And from the day I saw you first in the locker room, I could tell you're just fully engaged with the players one on one, and they trust you and care about you. So that comes through. You can even see in your body language, and it's
Oh,
really
well,
awesome.
that's awesome. I appreciate that, and I think that with my whole staff. I mean, you're exactly right. If you truly do care and you're a natural caregiver, or what I see is an other-centered person, you can be authentic to yourself and just do that. And you nailed it. We can't do our job without trust, Doc. Isn't it amazing? And trust has to be earned. It's earned by and not earned by just what you do. A lot of times, people, you earn your trust by successful outcomes. By no means do I not think you got to have successful outcomes to earn trust in our business. But these guys authentically, naturally know when somebody truly cares about them. They can feel that. We all can feel that. And so I think those are really key components. If you love this profession or be in this profession, you got to genuinely care about these guys. And I sure do.
Yeah, it comes across. The other part is the breadth of medicine. You got to know where it's like you got to take care of head colds and the coronavirus and broken necks and everything in between. So you got to, they got to know you care about them. At the same time, you got to know your stuff, and you got to know a lot of stuff.
Yeah.
How do you stay up on knowing the entirety of medicine? You got to know more medicine than I do.
Yeah. Well, I wouldn't say that because you're super smart and you're great at what you do. I would say it really comes down to is once again, it's just the addictive and the passion of this profession. You can't do this profession halfway. You can't do this profession in it to make money. Or you have to be really what I say addicted, a rage of mastery, and I love it. People, what's your hobby? I love to golf, do. But at the end of the day, I want to learn about medicine. And so I'm so intrigued about it. And, people taught me a long time ago, different, understanding various different types of medicines that, like you said, all the way from the common cold, all the way down to different viruses, all the way down to what we do in the orthopedic world. So it's just a constant learning and I just enjoy it. I mean, it's just what I wake up and I love to do. And I think that's probably been a big credit to it. And lastly, for sure, great people around me. Just being with you, Dr. Watkins, and all the stuff I've learned from you, just from the spine and that orthopedic specialty. I walk around and get this act like I'm really smart, and I just learned something that you taught me.
All right, nice. And as far as so you've been an athletic trainer in the NFL for like 20 years now, right?
Yeah, man, I got it in 2002. Gosh, it's crazy.
Yeah.
It's been 20 years.
Yeah,
Yikes. We
right.
didn't know it,
And
man.
you've been with the Rams for about 10, is that right?
About 10 years, 2010, I got the head job in 2010 as a head athletic trainer in St. Louis Rams. So
Yeah.
Steve Spagnuolo hired me.
Yeah, nice. I think that's when we first got acquainted with each other. Is my dad and I took care of Steven Jackson the
Yep.
running back from Oregon State, who had an amazing career, didn't he?
That way he really did. He's a special human being. Really passionate about the game. You're right. I came out actually to LA with you guys and got to meet you guys for the first time, and that was really cool. That's funny.
Yeah.
You remember that?
Right. And then now that your official title with the Rams is the senior director of sports medicine and performance, and so that that kind of speaks to where being an athletic trainer has progressed to, or it's not just putting on tape and stuff like that and patching people together and carrying bags around, but and which is I'm sure is great for you because all the learning and everything that goes into being an expert in sports medicine and performance
Yeah.
prevention and maximizing all that type of stuff. The science behind what you do has probably grown exponentially in 20 years, huh?
Oh, it's funny you say that, and it's funny we're dealing with that right now, kind of in our profession. The modeling of our profession is changing. It's funny you say that. I'm very, very fortunate and blessed to kind of oversee the strength and conditioning department, and nutrition department, the medical department, sports science, and what's happening. What you can see what's going on in our profession is you get this huge influx of merging of sciences, right? This collaboration, this holistic approach is happening right in front of us. And then you got this influx of subspecialties. We didn't have nutritionists 10 years ago. We didn't have sports scientists. Now we have, soft tissue specialists, people that just focus on that. And so you got this merging of scientists, you got this subspecialty, entity, which I think you probably can see even in orthopedics. And all that merging's really created this model or this umbrella of this holistic approach to player care. And I've been fortunate to be with the Rams and they've bought into it. And I've been able to kind of build that and now kind of, being over top of that, allowing a good environment for optimized and alignment of care, i.e. if we got a guy that's, we call it going through the car wash of care, you got the strength, nutrition, sports science, medical. We're all in alignment along under the doctor's supervision to make sure this guy comes out of the back end in his most optimal ability to be on the field and do well. And then lastly, with that, the performance aspect of it, not only from a medical component, guy getting hurt, getting back, but how can we optimize these guys even though they're healthy? Maximizing their ability or their readiness on game day. It's a booming world, and we're fortunate to kind of be rolling with it.
Yeah, let me ask you a couple questions about sorting that out because I deal with that too. In LA, we got specialists in all sorts of fields and trying to sort out who's legit, who really has something to offer versus who's kind of a quack. And, how much do you have outside? Do you have to deal with a lot of outside specialists that players, have or whoever else, whatever source there is? Oh, you got to use this guy for this. And do you get a lot of that? And do you have to vet people and how legitimate are they?
Yeah, you do. There's a lot of different, call it sciences, gurus, techniques out there. There's a lot out there, Doc. So what we try to do is this. This is our approach. Number one, we want to give good quality care within the house. So guys come to the Rams knowing that they're going to get optimal care. That's number one, right? Then also really looking at all these different sciences out there and say, what can we provide for these guys in-house? Because a lot of things we want to make sure we have provide for them. And then also going back to your earned trust, if we give quality, good care and earn trust, what you'll get a lot of times is these guys will come to us. Hey, I got this guy that's trying to put this product or do this on me. And the fact that we've earned trust with them, we can educate them on those things. Hey, be careful with that. Not sure about this product. Not sure what this is going to do to your body systemically. You got it, Reg. Trust you. I won't do it. That's kind of, I think, how our environment has started to work, and it's really benefited us because guys come to us and ask us. And then if we know it's not going to hurt them or it's not harmful and there's not a lot of evidence behind it, we'll say, hey, be smart, be safe. Heck, give us some feedback on it. Maybe we want to influence or not influence, but introduce it into our system. Yeah. So that's kind of how we kind of control that. But it's a lot out there that you really got to monitor and make sure these guys are getting good care.
Have you gotten any sense of some of these biologic injections like PRP and stem cells? Have you gotten enough experience with players getting it that you have a sense as to what do you think any of them work or for specific conditions?
Yeah, great question. From a practice-based evidence component to it, because we know where it's at in the science and the evidence and the research. Anecdotally, we get some guys that really feel like they do well with it. I think Dr. Elatrash and the whole team at Curlin and Jove have been, leaders in this area, and we need more research behind it. We know. I think our approach is this, right? We know what biologics is. At this point in time, we don't think it's harmful. We're not sure if it absolutely does the benefits we think, but we introduced it based on those parameters. We know it's safe. It could benefit. Can we do it? And when we do it on guys, if we do it on 3 guys, 1.5 guys say it does pretty well for them. And that's our world. Unfortunately, we're kind of on the front end of cutting edge of medicine, so that's a really sensitive thing that we have to deal with a lot.
Yeah, I hear you. I feel the same way with the spines, and for the spines, I still do steroid injections because they got a proven track record, and they decrease the inflammation around the nerve. Whereas we're not really looking for regeneration, because that's more of a chronic degenerative disc disease. That's more for 40, 50, 60-year-old than a 22-year-old. But
right. What I like about our stuff, talk about the knee, for instance, Dr. Watkins, what I think is really cool is what I do like about the biologic world. Okay, so we got the chronic knee condition, right? Where surgical intervention is probably not going to help this guy. And we got career ending, right? Here's the career about to end. This knee could end their career. And you got these guys that are really tough. I mean, they still can play, but they're in pain and they're trying to find, anything. And it's this gap. It's that gap from where they can't play no more, but they got a chronic knee condition, and you're trying to help them. We're doing all this stuff from a rehabilitation standpoint. We're managing them on the field, and they need something. I have found that biologics is something that you can give them that maybe can get them over the hump anecdotally, maybe it's subjective, maybe whatever, but it is a nice space or a nice gap that we have and we haven't solved yet. Yeah. That I think has a place,
Yeah. You mentioned their pain thresholds can be pretty high. The most impressive thing I've experienced, because my dad and I were consults for a lot of the NFL teams and agents, for years, because LA didn't have a pro team. And my dad took care of the college team, but college, is different because if a kid has an injury, you just say you can't play, and that's kind of the end of it. It's because they're kids for the most part.
Sure.
For the pros, man, a lot of what we depend on is, well, how much pain are you having? Like, is this disc injury fresh or not? Well, does it hurt? Because if it hurts, it's probably fresh. If it doesn't hurt, it may be old. So we're kind of dependent on somebody, expressing pain to know, is the injury new, and should it be risky? Should we protect him and not let him play? But man, football players, they don't feel pain. If you ask them what's your pain 1 out of 10, they'll never give you a number. I have never been able to get a number. They'll say, either it's all right or whatever, but never actually a number on it. And so do you have any tips? How do you get a sense as to where you really got to help this guy, and sometimes protect him from himself to some degree?
Absolutely. And how many times do we say that? We got to protect you from yourself. That subjective measurement, what these guys are capable is amazing. Yeah. They're amazing human beings. And it's such a special treat to be able to work with guys like this, because I always say it all the time, they've pushed sports medicine because of the capabilities of being able to play with things that you never thought in a million years these guys can play with. And honestly, that toughness for us in the athletic training business, and I know a lot of people that work in professional levels, we always say, tough players make good athletic trainers, and our job really at the end of the day is, I find myself a lot of times protecting these guys from a safety perspective more than, can they play? Because most of the times, you're right, their pain threshold is amazingly high. And I've never seen anything like it. It is really a neat thing, and it shows you how special they are.
Yeah, comparing the sports, there's no doubt about that, where it's like if somebody gets a fresh disc herniation or it looks like it's fresh, generally it's a 4 to 6 week recovery. But in a football player, 3 days later, they're like, I got no pain, I can move my neck. They're ready to play. And then it's a question. Then it's a real question of, well, how dangerous is this? What's the risk assessment and stuff like that?
Yeah.
And then it takes a close working relationship where I can, it's like I call you and go, hey, is this guy really having pain or not? And does he ever?
Yeah, no, and that helps, and that's when it goes back to the relationship and having a good connection and knowing guys. Rookies, takes me a little while to get to know them. You could ask me about a rookie, Doc. Reg, what do you think about this rookie? I'm like, man, Doc, I'm still getting to feel him out a little bit versus maybe a 7-8 year vet. I mean, I know exactly how tough Aaron Donald is, right? We all know that. And so it's being able to balance that. I think the other neat thing too, you're exactly right that we are challenged with in the rehab side of things, as much as even from post-surgical things, is with their pain threshold is surgical morbidity. Looking at pain thresholds, you're exactly right. Even functional gains, i.e., you got to get a herniated disc. Okay, we got to get his range of motion, pain levels back. Their functional gains are so much quicker than the tissue healing process.
Yeah.
You know, I get you all the time. You say, Doc, you'll say, hey, Reggie, this guy has a fresh disc herniation. I'm like, Doc, he has full range of motion, his neck's great strength, but me and you both know that tissue's not healed.
Yeah.
And it's really interesting to see how we've gained because of rehab techniques, because of surgical techniques, that we're almost faster than tissue healing.
Right. Right.
It makes sense. I mean, I talk to Eltros about this all the time, and it's hard to, is this guy saving to play from a tissue healing standpoint because functionally he's there, pain's there? What do you do?
Right.
Interesting.
Is there any way to reproduce the load? Like, for instance, say a guy gets a fresh disc herniation in his neck, and it looks fresh on the MRI, new symptoms, but they go away pretty quickly. And so this may be a stable disc and maybe pretty safe to go back. And that's where, my job is kind of the risk assessment. Well, is it a 1% risk that he gets injured? Is it going to lead to surgery, or is it going to lead to paralysis? What is the odds assessment? But part of it is there a way to reproduce football and an axial impact without actually playing? So is there a gradual way where you can kind of, ease them back and test it a little bit? Have you found any success or techniques for doing that?
Yeah, that's a great question. And the answer is really no, I haven't. It is because especially when you're dealing with the cervical spine, I mean, most of the mechanisms that you're talking about are pretty provocative, and it's hard to really simulate. Definitely range of motion things, definitely the art of football in terms of when you watch a guy, prime example from a range of motion, disc herniation, a receiver, linebacker fitting up in the blocks and stuff like that. You can do some football specific things, but there's probably nothing that you simulate as much as a violent tackle in a game. And we don't tackle or we don't hit anymore in practice, right? So my thought process is talk to you, like you said. I think you give me the techniques of, hey, Reggie, I think this guy's safe to play. Let's rule that out. Now, what I take the next steps is can I look at the mechanism of injuries and can I make it safer for him to play by maybe controlling some of those mechanisms of injuries? I.e., a guy you might say, okay, left side cervical disc herniation, so we got to watch extension and left side rotation. Can I limit that a little bit and still be safe? Can I put a curve collar on him? Can I do something that? So now you just said, Reggie, he's safe to play. And then I took it up one more notch based on understanding mechanism of injury, understanding what it is, that, hey, I just made it a little bit safer, and those are some of the things that I think the strategies are all we can do. But other than that, it's hard to simulate to see, hey, this tissue really can take on the load that it needs to take on, if that makes sense.
Right, absolutely. And those Kerr collars, the collars that go inside the pads the biggest thing we see, and we can talk about now, is the stingers that go down the arm. And that's generally in an older person. And young kids, it can be a stretch injury, the brachial plexus. But generally in people in their late teens and 20s and the athletes we see, it's extension and rotation to the same side, head compression. It pinches the dorsal root ganglion in the foramen, irritates the nerve, causes the numbness, weakness, pain down the arm, and as a stinger, burner. Those neck rolls. Do you feel like those can be effective without restricting the range of motion and making it more risky for them to play?
Yeah, I think so. I think we use the Kerr collar, and that actually has done a really good job. Where two things, you feel like they still have enough extension to take that risk out, right? Because obviously, what you don't want to do is limit extension, and now you put them more susceptible to axial load. Know exactly what you're thinking there. So we want to have some range and some give, but we don't want that extreme in range motion. The other big thing with it, to be honest with you, is two things. Is one, it's having enough motion to be able to do their job, right? Get in the stance, look up, receiver turning their heads. That's some of the issues that you usually get. The other thing too, I hate to say it, is the reality of his compliancy, because they're the swag of it. Like, these guys just hate, neck rolls. They want to look slick. They don't want stuff. So that's usually your issue with it. But we haven't found any issues from a safety or anything. And I'll be honest with you, we've been pretty effective actually with some guys going back with some nerve injuries, brachial plexus stretch, or with the impingement side of things, and still do well with them.
Yeah. Let's move on to more of the dramatic issues of and the scenario of basically if a guy goes down on the field, big injury, big collision, he goes down, and you suspect a neck injury, and you're on the front lines, and it reminded me of the playoff game where Wolford took the hit to the head, and
Sure.
you had to run out on the field, and you had to assess what's going on, and we obviously won't talk about any specific cases, but what's going through your head? National TV playoff game, bright lights are on, and you're running out on the field to assess somebody on the ground. What's going through your head? What are the things you're thinking about, and what's your mindset of how to really make sure you do your job?
Absolutely. Jumbotron medicine at its finest right there, right? And so I think number one, the mindset that you have is all based off of your practice and your process. And I don't want to go too far back with it, Doc, and I'll answer your question, but I think it does start with that is, have you practiced and have you prepared yourself for this moment? We do an emergency action plan every year. We get Mike Sedoma from Sports Medicine Concepts. We come down and we do a huge on-field, emergency action plan for C-spine injuries for worst case scenarios, all the way up to your not so-called worst case scenarios. And you really have to go through that process. So when you have that area that you feel prepared. So now going full circle to that moment, you're exactly right. You're trusting your process because things are heightened, sensitivity's heightened. And the first thing that comes to mind when that happens for me, I'm running on the field is, as big as this feels, the first thing I do is tell myself, slow down.
Wow.
You have to slow down. You have all the time in the world. Because I think what happens is the first thing we think is, oh gosh, big deal. We got to hurry up. And I think when you rush, I'd rather slow and right than fast and wrong. And so the first thing I tell me is slow down, take a deep breath. We're okay. I think the other big thing is athletic trainers, what I give advice to is watch the field and make sure you're truly watching, for mechanism of injuries, watching for anything you can see. I think that's critical. I think a lot of times we can get caught in games. Here's a playoff game. We're trying to win. We're trying to go to the next round. But at the end of the day, my job is to make sure that I can watch the game for any type of injuries. And I think it's critical to see as mechanism of injuries what happens out there. And going back to Wofford's scenario, when you saw the hit, couldn't see the total mechanism. But what I did assess when I ran out on the field, that he was moving, he was rotating over, he was pulling his helmet off with both hands. He came down, he was kind of grabbing his head a little bit. So right then and there, I instantly run on the field. As you don't think, we don't have a paralysis situation, at that point in time. And I think that's really critical to know. And then when you get out there, that's when you trust your process. Yeah, I went down there, had Dr. Elatrosh. We have we call it a critical triangle team, where we have our assessment, a doctor assessing. I'm controlling the C-spine by controlling the head. I have another doctor who's what we call our code runner, who is kind of running the code of our process, kind of our audit check. And then I have my other athletic trainers that are ready for any type of spinal board, equipment, spinal board care, spinal boards that we might need, and any equipment removal that we might need. So everybody knows their roles, knows their responsibilities, and we go through our process.
Yeah.
And we trust our process and our algorithm to get to our answer.
Yeah, it's kind of like a pilot and a co-pilot. That's great, actually. When I operate, I usually operate with another surgeon. We have a great PA, but either my dad or Dave has been with us forever, and having a co-pilot there who knows the steps and is kind of standing back watching and just going, oh yeah, what about step 4B? That's great. I hadn't thought of that. And of all the lectures I've given in cervical spine injuries, I've never actually pointed that out, but it's a great thing. Because like you said, your brain speeds up. I'll tell you a quick funny story about Tommy Lasorda. He passed away. My dad told the story recently. Before my dad operated on his wife, Tommy was like, Dr. Watkins, I just want you to know you're the greatest surgeon of all time. You're going to get in there and do a great job. And my dad went, Tommy, we try and slow things down. I'm not trying to get pumped up for this. I'm trying to what you said, it's like, slow it down. You got all the time in the world, especially if somebody's face up and they're breathing. Yes. Slow it down, take your time, have your check person next to you. That's really great advice. What do you do if somebody is face down?
Yeah.
Yeah. How? Yeah.
And honestly, that's a great question, and that's what it gets to, right? When we do our emergency action plan training, we train for worst case scenarios. Those are the ones that can get scary, and so you've got to be prepared for those. So you got the face down guy that took a true axial load, and you get out there, and obviously number one is you got to go out there with the understanding, especially if they're not moving. Once again, I think it's so critical to assess when you go out there. If they're not moving and they're face down, you got to think worst case scenario. You got to establish consciousness. You got to look back at your airway, you're breathing. You got to see if there's circulation going on. You got to go back to that stuff, and then the algorithm goes to me from worst case to your, I hate to say it, to your orthopedic assessment. Prime example: right. If a guy is face down, and we get indication that he's unconscious and he's not breathing, doc. Be honest with you, that takes precedent over the spine at that point in time.
Right.
And so we got that algorithm. We got to get this guy rolled over and we got to expose his airway, period. Yep. That's the algorithm. Everything's off the board. So, people all of a sudden will think of that situation and say to themselves, well, we still get the guy over and let's establish an airway. The guy's not breathing. That's number one. And so you got to go through those algorithms with it. And when you hit one, you stop. And we call stay and play. You stop and you evaluate that situation and you attack that particular spot. But once again, it's that nice algorithm that you have that allows you to do that.
Yeah. And then as far as, and so if a guy say is, the big things, like if he's unconscious, if he's got paralysis, in both his arms, and if it's both arms, both legs, you're more concerned than if it's just one arm, right?
Absolutely. I mean, I think we know unilateral versus bilateral is a big key indicator with what we call that spinal cord injury versus most of the time your peripheral type injuries, which might be more of your unilaterals. That's big indicators for us. Guys face down. Let's say we get past our worst case stuff where the guy is conscious, he's there, and we're okay while they're face down. I think is a great ability to be able to palpate right there. If we know we don't have to rush to turn them over because we're not trying to establish any type of worst case stuff, palpate the C-spine. You can already do some of your neurological assessment, and that'll give you some key indicators right there that, hey, how serious this case. And then obviously when you start to proceed to do your, get them face up with whatever type of method you use, those are really good. Once again, slow down, do your evaluation when they're face down is okay.
So if we've got him face up and he can move his arms and legs, and this applies to men and women, obviously, but for football, professional football, I tend to use the male term. So if we've got him face up and he can move his arms and legs, he's conscious. If those things are out, you'll board him. But if he's conscious and moving everything, if he's got some neck pain, I mean, those are the gray zone, right? Because now we're trying to figure out, okay, is it stable or unstable?
Yeah.
And we already talked about how these football players have high pain thresholds, especially with the adrenaline running and everything else. So if he's got some neck pain, how do you kind of get a sense? You said you palpate him, you see if he's tender. Is a lot of that too the experience? You kind of get a sense as to how much pain do you think this is?
Yeah, that's great. I mean, now you're in the gray zone, and that's tough. I would say two things. Number one, at that point in time, it's about trusting your gut and trusting the mechanism and really trusting your algorithm, right? Okay, they got, they have C-spine, do they have midline pain? But all extremities are working good. You do a little compression test on them. I mean, how immense pain is that? I mean, are they squinching? Are they really, how bad is it? And you really got to assess that. And once again, going back to the mechanism and make that judgment call. At the end of the day, should you err on the side conservative and board them? When in doubt, I would say with gray, do that. But if, especially if it's bilateral, you get those transient deals where they get bilateral transient for a little bit, but it comes back. Okay. You probably might have did a little something to the cord there for a bilateral incident, even though you got everything back. That tells me that's still a little bit more towards the conservative side versus, once again, that unilateral, which tells me probably less spinal cord, more peripheral. Yeah. So it's just different nuances there. But we're in the gray, think conservative, take your time. I think one more step to the gray too is what we do. And I think in Wofford's situation, like I said, not to get specifics, you got to go through your algorithm, but you declare that you're not going to board a guy. You sit a guy up. Take your time there. You sit a guy up, you evaluate, you do a compression test, you check extremities again, you can get increased symptoms.
Right.
And I think what people will say a lot of times, Doc, is guys sitting up, you can't board them. Oh, yes, you can. Put them, if you feel like this guy increased symptoms or he comes up and there's something there that increases, lay him back down, control the spine and board him. That's okay. We talk that all the time with Mike Sodoma and stuff, and that's very safe to do. It might be better than getting them up and walking him off the field. I think a lot of times we miss that, if that makes sense.
That's an excellent point. I mean, yeah, because you think once you sit them up, you're going to get some axial loading.
Mm-hmm.
You may get increased symptoms. And like you said, to go back into boredom, you may be worried about how's it going to look and stuff like that. It doesn't matter because you had a change of the scenario in the sitting up. You tested it. If they didn't pass, put them back down and board them. And you're right. A lot of it is staying focused on slow things down, do what's best for the person, period. If you have any question, err on the safe side.
Yeah.
What about moving to the next step of they've got some neck pain, seems okay. You sit them up, they seem okay. They stand up, they walk off the field. Mm-hmm. So because the two main questions we're looking at are, do you board them or not? And if we say, okay, you don't need to board them. But then the second question is, well, can they go back in the game? Because it is a playoff game and they want to go back. And what do you look for on the sideline as far as in your exam on the sideline? What's going to tell you can't go back in the game?
Yeah, and that's what's so critical. And you watch our doctors, and it really going back to our doctors and our neurological assessment and trusting that in your C-spine assessment. Obviously pronounced weakness, right? You're positive, all your positive provocative tests for C-spine. These are no brainers. And then obviously going back to really trusting now, we have the ability for scans, right? You got to get your x-rays, CT scans are not that, you get something in the first quarter. I mean, you love what the NFL has done in terms of really having really immediate care where we can get CT scans and stuff like that quickly. So obviously leaning on that as a diagnostic tool is so critical too. But, I'd be honest with you, for a guy to go back in that have pretty pronounced symptoms on the field, it'd be pretty hard to convince most of the time, because most of the time when we get those, we do have lingering symptoms when they come off the field that declares them out. But trust diagnostics, trust your neurological exam, your special tests from a cervical spine, and then make that judgment call. And I think it goes back to what you always say. Do we think this guy is safe to play? And also, too, I think the next step is, once you do that, will this guy be able to perform at the level that he needs to perform better than the next guy up? That's the other thing, too, I think, to think about.
Right, absolutely. My dad had a player in college who had a collision on the field, came over, full exam was normal, full range of motion, no symptoms down the arm, didn't have any pain. And he literally went to put his helmet back on. He kind of winced when he put his helmet on. And my dad was smart enough to go, wait, hold on. That's weird. That's abnormal. That's not normal. Yeah, and just held him out and got a CT scan. He had a lateral mass fracture, wow. Which is a pretty stable injury. And if he had gone back to play, probably would have been okay. But at the same time, some of the cases we've seen from all over the country are those types of cases where a guy has some neck pain, not that bad. He's allowed to continue to play, turns out to have some type of fracture. And then it gets really dicey, because you should not have let him go back to play with a fractured neck. That's pretty obvious. But how stable and how risky was it? Did it really change his long-term future? It might not have. But that's where, just what you said, if a guy's got a violent collision, still has some lingering symptoms at the same game, you should probably pull him out unless he's completely symptom-free.
Correct. I think what's really neat about you, Dr. Watkins, and I love you, and even just your father from all these years, is, I think what you guys appreciate, and it's so tough, especially in your world, is the advancement of guys getting back to the field, the shortening of their return to play, or even in game, has advanced over the years by really players kind of showing that they can play with more do you think. It really has. People talk about, like, why do we get now where guys are coming back 6, 7, 8 months from ACL surgeries? What's changed? Surgical advancement, stuff like that. But also people pushing the envelope and showing that these guys can do things. We have tibial plateau fractures that I never thought in a million years these guys could play with these things in their knee. And these guys come back in 2 weeks and do well. How'd that happen? Well, it's the advancement of these players and what they're capable of doing. And I think what's really neat about you guys is that you guys over the years, because of your experience and what you guys seen in a very sensitive area called the neck, right? We all know when we hear neck, everybody freaks out, but stable versus unstable. Like, truly, is it stable? Can these guys play? And we can't get too freaked out. And we're learning that guys are capable at a safe way to be able to do things. I think it's really neat of our advancement in our professions. It's really
Yeah,
these guys driving it.
it's so true. 20 years ago, it was like if a guy had a significant injury or like had a fusion of his neck and had some mild symptoms or changed at the level above, the easy answer was don't play anymore. Like you're done. But then you get a couple cases where a player is, well educated, listens to the whole story, and he goes, okay, I've heard everything you said. I'm okay taking the risk. If you're telling me it's a 1% risk of being paralyzed and a 10 to 20% risk I'll have future injuries, future issues, but a 70 to 80% chance I'll be okay, and he does all the rehab and everything else. They'll push you where it's like, well, yeah, you kind of can play,
Yeah.
and then they go back and they play another 5 or 10 years and have no issues. And you're like, okay, well, maybe this is okay.
Yep, successful outcomes. I always call it successful outcomes piling on top of each other gives you clarity, and it gives you clarity and evidence, and so we definitely have been advanced by, once again, going back to the player, have they really proven the things that he can play with is really amazing.
Yeah, it's really true. Well, that's great, man. I really appreciate it. Oh, let me say one other thing about the stingers and the burners. I think one other thing to note is, stingers. So we'll take stingers. Well, I want to mention two things. One is you mentioned the transient quadric event where the guy gets burners, stingers down both arms, spinal cord injury. Could be really quick, though. Could be a 5-10 second shot.
Absolutely.
And typically you don't want to let them go back in the game, get a proper evaluation, see how things look. And for us, I can tell you a big part of our decision making as to what's the risk of future injury and can they go back and play.
Sure.
The textbooks say if you have 1 or 2 episodes, you can play. If you have 3, you can't play. But for us, it's much more gray zone than that, in that we need to know how significant the event was. Was
Right.
it burning and singing and numbness down his arms for 5 minutes, or was it for 5 seconds? Because that
Right.
indicates the severity of the episode. And we really rely on the trainers because the players either don't remember or won't tell us. And so
Yeah,
getting
no
it
doubt.
from the training staff, like, hey, how significant was this big? And then the other part is the stingers. Of note is there are guys who have some narrowing of a hole and get 2-3 stingers a year, and stuff like that. So sometimes it's safe to play with, but
Yeah.
that's if we understand the situation. They've got MRIs, they got CTs. We really know what we're dealing with. Then and then like you said, the guy. You can get a sense as to, is this just a quick one? We know what the pathology is. He may be able to go back the same game even.
Yeah, absolutely. And you nailed it. The bilateral and transient situations, no brainer there. You board those and you got to get those. And I think it's really good. I'm glad you said it. That's good knowledge for me that your code run or whatever, if you can get the timing of that, how long it was, what did they remember? I mean, if you get out there and they still are not moving their arms and all of a sudden they start moving both hand and finger, I mean, that's real. Versus the ones that say, hey, when you get out there and they'll say, hey, couldn't feel both. I mean, both my hands felt really tingly. Like, okay, that now you're talking more cord. But the stingers, absolutely. Knowing the anatomy, knowing the structure what these guys are dealing with is critical. And I think you've helped us out with a lot with that. Is, hey, get scans on these guys that get them. We've over the, I would go back 7-8 years ago. I mean, a guy get a stinger, come up, oh, I got a stinger. I'll tell you, give me a second. I go back in the game and it's like, go play. And not that that's, was it wrong or right, but I think, like you said, structurally understanding what's going on gives you more clarity to allow these guys to play. And I will throw one more thing out there. I think it's really neat to talk about stingers. And this is my experience as an athletic trainer. And I would love to, tell all the athletic trainers out there that maybe if they have a better idea or whatever, let me know. But rehabbing stingers, right? I have not beat a nerve yet when it comes to treatment of a stinger. They always win.
Yeah.
And it's funny when I say that is that, people get these stingers and it's like, I think as therapists and athletic trainers, the first thing we think of is let's treat this thing, let's get it better. Let's treat. And you know what I found personally? When we do that to nerves, we make them angrier.
Yeah.
Electrical stimulation, adding a lot of ice to them, trying to do a whole bunch of soft tissue work, things of that nature. And it's like, sit there and, I mean, a guy has weakness. Okay. We have a guy that has a little bit of weakness because we know he has a stinger. I always look at the stinger, right? The key to the muscle, right? It's the key to ignition. It's not the actual engine. So I'll sit there and try to do a neuromuscular re-education on their deltoid, things of that nature. Guy comes back the next day, I feel horrible.
Yeah.
And my lesson I would say to people is, if you have figured out a way to rehab a nerve, let me know. It's the longest healing tissue in the body. I found, let the nerve be.
Yeah.
Heal. Less is more.
Yeah.
Soft tissue work around the area because they have a stiff neck, spasm. Get that, but be light with it.
Yeah.
I've learned less is more with nerve, and I'm interested if you heard anything differently too with that. But just a little nugget for people: don't get too exotic with those things.
I agree 100% in that, especially if somebody has some weakness, everybody wants to know, well, what can we do? How can we get to work? We do. What you can do is leave it alone and let that, and a couple of reasons for that. And as far as like e-stim and, medication, stuff like even steroids have never been shown to help a nerve recover definitively. We do them because they help with the pain. They may help with the inflammation. They're young and healthy. There's no downside. But in reality, leave the nerve alone. And part of it is it's the dorsal root ganglion, which is the most sensitive part of the nerve. And so you ding that part, it's where the cell body sits, which has the Golgi apparatus and mitochondria and everything. And then the arm goes out as the dendrite. That dorsal root ganglion is the most sensitive part of the nerve. You ding it, it hurts like hell. And you're right, just leave it alone. Because if you do too much, you're just going to keep irritating it. So torquing on somebody's neck, and obviously if you go back into that position and you hit it again, you're just going to keep
asking for it.
The worst thing you can do. What we do is in our program in the app, the Back Doctor, we start on your core. So it shows you how much we leave the neck alone. We don't even want it to do anything to it. We want to work on your back muscles, do some dead bugs, start firing your core and build up the base and work on that, and then work your way up. And then the chest out posture exercises can help. I'll do my side view, because when you go like this, you're pinching the nerve. And so if you're slumped, you extend your neck and you pinch the nerve, just like the Sperlings. But if you stick your chest out and let your head come back over your body, it helps dynamically open up the foramen and can take some pressure off the nerve. So doing the scapula stabilization and chest out posture exercises, can help. And we certainly see that in chronic neck conditions and people sitting jobs, they do that. It helps the neck. And a football player, I agree with you, where it's like, we do that because you can, and it's not going to irritate the neck. You can start doing something and help build up some strength. Ultimately, I really think that in football players, building up some mass bulk neck muscle, probably does help. And we don't recommend that for normal people. You got those contractions where they I see it on Instagram where a guy's got a thing on his head and something in his mouth and he's ripping his head around and, it looks like a nightmare, an injury creator. Yeah. But there's something to be said for football players, especially having a thicker neck, I do think would help you after you've done all the postural stuff.
Exactly right. And that's what we do for the acute injuries with the stingers. Exactly right. What I say is, let's put the neck in a postural good spot to decompress the nerve. Yeah. Put the neck in a position, allow the nerve to rest. You're exactly right. We'll start a little traction, some decompression stuff later down the road, potentially. Once again, what are we doing, Doc? We're letting the nerve heal and keeping away from doing anything damage to it. So I definitely would do that. From a preventative standpoint, let's get to the off season. I don't have a stinger, but we're going to do that. Absolutely. I mean, you got a lot of strength coaches out there to talk about different neck programs, but you got to think about it. Once again, it's going back to the mechanism. What is the mechanism? Tempo is extension and rotation. So really eccentric exercises to really decelerate extension and rotation. Can your SCMs, can your muscles in the anterior aspect of your neck decelerate the mechanism of your injury? To me, are things you can do preventatively wise, do a manual therapy, things of that nature, just to really control that and really get guys eccentrically getting those muscles to work. Are good things that we've been doing for ages that are still worth doing now. And then I think also too, like you said, working scap stabilizers, good posture, good core. You love all those things. And the last piece I will say to that too is one of the biggest key indicators in terms of reducing injury with that is going back to the fundamentals of tackling.
Right.
You'd be surprised, Doc, going full circle, how athletic these guys have gotten, and they lost the art of how to tackle. They want to knock your socks off. Right. I'm just going to hit you. But now what we do is we call shoulder leverage tackling, where we have guys tackling. We used to do was called, head leverage tackling. A guy's coming, I put my head out there and I try to use my head to stop the guy from coming. Yeah. Well, we're finding out that that's putting necks at risk. That's knocking your guy out. Now we're losing guys. Availability goes down. Let's get back to good technique where we call shoulder leverage tackling when the guy's coming. I'm going to use my shoulder and my arm to tackle you, not my head, reducing concussions, reducing stingers, and also too wrapping and rolling, teaching guys how to wrap and roll. So that's another thing that I think is a lost art to this thing, is really getting back to the techniques of how we tackle to take what we said, the neck and the head out of the game.
Right. How much do you feel like not hitting and tackling in practice? Do you think, I mean, obviously it decreases injuries in practice, which, some seasons I know in the college ranks, it's like they'd lose 25% of the guys in practice, so obviously that's good, less injuries in practice, but how much do you think it increases the risk for injury in a game, or do you think it just makes for a little bit worse defense in the games?
Yeah, probably. I don't think we can see a correlation to less injuries in a game. I don't. I think that exposure in practice is so critical, and you can't tackle anymore. That makes all the sense in the world, and I just don't think there's any correlation there. I think the correlation you see goes past that. Typically, it's more, I would love to see the correlation of their upbringing and really being taught tackling. The whole heads up program that the NFL initiated, things of that nature, is getting back to the fundamentals of it. And because we'll get guys that will come in and we'll see their technique and like, wow, they just hit you. They're not tackling you. I mean, they're throwing their body in there. And so I think our coaches have actually done a good job of teaching technique without truly tackling. There's a lot of good drills out there. So I do think technique can get better. I do think you can do it without tackling, but I do think where the loss is going back, just being taught how to do it. But if you're taught how to do it, I think it can correlate to the game, and you can actually take somebody down and tackle,
I might mention one other thing about that, I don't think fans entirely appreciate that a game of yardage where every inch matters is going to predispose players to lower their head, to torpedo, because that is the way to generate the most force. And so you're going to have neck injuries because it's the nature of the game. Every inch matters. It's so vital. But by all means, it's the NFL's done a remarkable job for what a rough sport it is. I mean, the rule changes have made a big difference. They've decreased neck injuries and concussions, and it helps. It's actually making a difference, which is great.
It really has. I'm so excited of what the NFL has done from a player health and safety standpoint. They initiated this stuff 17 years ago, and you think about it. When it happened, everybody was like, holy smokes. I mean, this is going to change the game. And I tell you what, you're really starting to finally see the fruit of it. I really do. I think concussions are going down, neck injuries are going down. And in the advancement with BioCore now, which is a company that they contracted with, that's looking at all types of mechanisms of injuries and all types of research on helmets and what we do from tackling and form, and looking at biomechanics of different mechanisms of injuries, lower extremity. It's really special, and our game's getting safer, and I think that's critical to keep this game alive.
Absolutely. Let me ask you one last question. Have you had any experience with players coming back after neck surgery, either this foraminotomy in the back of the microscope or a neck fusion? Have you had any of those?
You know what? The only one that I can think of from a fusion standpoint, it goes back to my Carolina days. Chris Winkie. And I don't know if did Doc do his surgery or not? Do you know?
I don't remember. I'm not sure.
He had a single level fusion, but I was a quarterback. But if you remember him coming out, that was a big deal.
Yeah.
Him coming out and he did great with us. Quarterback, once again, like I said, probably, obviously that position warrants, probably do pretty successful with that. He's the one that had, but other than that, Doc, I haven't had many of those, believe it or not. And obviously, I know you've seen a lot more than me, but how well they do from especially we'll call it linebacker, safety, some of those high level positions.
Yeah, it's a constant balance. The two main surgeries we do, the foraminotomy in the back of the microscope, is much smaller surgery, just make a little more room for the nerve, but it's limited because you still have this injury to the segment. And we've seen in some offensive linemen who take the hits to the head, it can irritate in other positions. And a neck fusion from the front, which is what we did on Peyton and a lot of football players, is a very safe, reproducible surgery. The guys can go back and play safely. And so we do both, but we tend to err more on doing the fusions because it locks that segment down. You never have to worry about it again.
Yeah. And those seem like the ones that you see. We see a couple in the combine. There's a couple of players that obviously are playing with it. And it's so funny. It's pretty neat once again, it's going back to some point in time when we let these go back and play. I remember when I first got in the league 20 years ago, you see that coming to combine, you're like, whoa,
Right.
Disqualification. Now single level fusion comes in the combine. We're like, oh, okay.
Right.
Guys, single level fusion, and he can play.
That's a good point too. Is if you saw a guy with a single level neck fusion versus if you saw an MRI that had a big disc and bad foraminal stenosis and looked bad, you'd almost rather have the guy with the neck fusion because it's already been fixed.
Isn't that wild? That's so true. Obviously, the risk of above and below that level that you got to monitor over time and something there. But you're exactly right. It'd be interesting to see, the grade evaluation on those guys. In comparison to how do we grade the single level fusions versus some of these guys that's these degenerative stuff that needs that lights up like a Christmas tree when you see it, like holy smokes. So pretty neat, but the advancement of medicine just goes to show that guys have played and done successful with it, that we're just not as uncomfortable with letting these guys play as we used to be.
Yeah, it's absolutely true. Well, thanks, man. I appreciate you coming on. That was fun.
Oh, that was awesome, man. Appreciate the time, and it's always good to learn from you and talk with you about this stuff. It's really cool.
Likewise. We'll stay in touch. Enjoy the last couple of days of your off season, and we'll get back to work soon.
That's it, man. Let's go get it. Appreciate you, Doc.
Yeah, likewise. Thanks, man. All right, Reggie. Take care.
All right, man. See you.